Hey, good morning. Good morning. Dr. Rosenthal was saying that he was predicting the best turnout for a grand rounds this year, and I think that looks right. I was lucky enough to be in a meeting with Gary the other day when Ruth came in and said, "Hey, we were supposed to have a grand round speaker, and there's a travel ban. He can't come." And Gary said, "Perfect. John, get together a COVID grand round so that we can talk about where we are in this pandemic now, where we are in departmental planning, because as a department, we should be making sure that we're aware of our plans. As an institution, we should be making sure we're aware of our plans. And each of our sections should be discussing where are we now, and what are we going to be doing in a couple of weeks? How are we going to handle this? So we called together 4 of the institution's experts. There is a relatively small group who's been working day and night for the last couple of weeks, putting us into a position to be able to respond to this effectively. And what we thought we would do this morning is let them give us a quick update and then just turn it over for some question and answer time, because I'm sure that lots of you have really, really good questions that we're all concerned about. So we're going to ask Werner Bischoff, our hospital epidemiologist, to update us exactly where we are in the epidemic.
So thank you very much, and good morning, everyone. Great crowd, which again is not really great for COVID-19, so we should avoid that. But anyway, so since we are all here, let's start that, and I will try to keep it very brief. But so this is kind of the first slide, and everybody knows that we have been exposed to human coronaviruses for decades, so that's not new. These are kind of the ones that cause the common cold every year. But then we have these other human coronaviruses there on the bottom. We have MERS-CoV, the Middle East Respiratory Syndrome. We have SARS-CoV, that was the one in 2002, floating through the world, and then was stopped actually with great infection prevention measures. And now we have the last one, the SARS-CoV-2. So that's the official name for this virus. So outbreak status, and now I'm actually putting the time where I actually kind of went on the internet on it, because it's changing pretty much every minute. And you can see that we have now over 127,000 cases worldwide. We have over 4,700 deaths. Countries affected, 125. And in the US, we have now 1,336 cases, 38 deaths. States affected, at least 38. The major ones are Washington State, New York State, and California. And in North Carolina, we have actually 8 cases within North Carolina. So we had 2 a few days ago, and then we had another 5. These were folks attending a conference in Boston and coming back here. And then we have another one actually in Wake County that is also linked to these cases, the 5 ones that came back here. So looking at the map, you can see the big red dots show kind of where it is really active. And again, mainland China is the biggest blob there still. But you can also see that we have cases in the Middle East, which is highly concerning, especially Iran is fighting it. And then we have cases in Europe, and you have also seen the news from Italy. So they are really fighting that, and they have a ton of cases here. They are testing a ton of people, but also they have a ton of fatalities. I always show that slide to give you an idea about the trends, the developments of that outbreak. You can see the dark yellow line there on top. That is mainland China. These are the numbers, and you can see how it's plateauing off, which is, of course, a good sign. So it doesn't seem to be spreading more in mainland China. However, be aware that Chinese government has changed the definition for cases at least 6 to 7 times. So the one thing that you see the blip going up there's where they changed one time the definition. So how can we be really sure that these are the data? But that is what we are getting right now. The green line is a line of cases that are recovered, that have recovered from COVID-19. Again, a good sign that it goes up. And then the light yellow line here, these are cases outside of mainland China. And you can see the steep increase there. So it actually has left China and is now going worldwide. Characteristics of COVID-19, fever, cough, shortness of breath. Some folks also have GI symptoms, which is not unusual for that they have seen in other respiratory viruses such as influenza. 80% of the folks have mild symptoms, so probably not requiring hospital admission, but 20% are going into the severe rounds there, and 5% out of the 20 actually are critical. So these are the numbers that we got from China. They may change a little bit, but I think that is what we have to prepare for, looking at where we are and where we may be. Incubation time, 2 to 14 days, on average 3 to 5 days. So that matches pretty much human coronaviruses as we know them, the ones that are circulating. And the transmission rate, or R naught, is estimated at 2 to 3. That means one person infects 2 to 3 other folks. So it's spreading the infection. An R naught of 1 would mean that it stays pretty much the same, it's endemic. And we try to get this R naught number down to less than 1, because then the outbreak is actually burning down and it's kind of leaving us. I put as comparison the seasonal influenza. The R naught number is 1.3, so lower than what we are expecting right now, or what we are seeing right now with the COVID-19. And SARS, then the old SARS, was 2. Fatality rates, it's very hard to estimate right now. What we are getting is actually numbers of people that need hospitalizations that are also tested. So we are not testing all the other ones that are maybe asymptomatic and are in the community, maybe have light cold symptoms but never show up for testing. Right now the estimate seems to be really high with 3.4% from WHO. However, epidemiologists say it probably is around 1.5 to 1% mortality for that virus. Again, comparison data here for seasonal influenza is 0.1 in a bad season. You know that from the United States, it's kind of 36,000 to 50,000 people die each year of the seasonal influenza. And MERS-CoV, which is still in the Middle East, is 34%. That's very high. However, human-to-human transmission of MERS-CoV is very rare. Usually you have contact to an animal that gives it to you, and then you are needing to go to the hospital. So my tip, if you have a camel at home, be careful with that. Yeah? SARS was 10%, and SARS again is the prime example. If we are doing infection prevention measures, we can contain outbreaks like that for respiratory viruses. We can get it down, the R naught number under 1, and burn it out. This is kind of a table of age and fatality rates, and I wanted to show that what is really interesting is that you don't see any fatalities in the age group from 0 to 9 years. So I think the immune system is building up in these folks here. They are exposed to a bunch of other common cold viruses. It doesn't really seem to affect them. However, what is concerning is going up there, 60-year-olds and up, 70-year-olds and 80-year-olds. These are the folks that are really vulnerable for COVID-19. So I'm very concerned about long-term care facilities here. And if we have outbreaks like in Washington State and the nursing facility, that can be devastating for these folks living there. These are some scenarios modeled after influenza outbreaks in the pandemic. And I just want to point out, so the moderate one is from 1968 influenza outbreaks, and then the very severe one is the 1918-1919 influenza pandemic. If you look at the numbers, medical care, both of them 38 million estimated now for today's standards. The moderate scenario is 1 million hospitalizations. The severe scenario is 9.6 million hospitalization. What is really concerning, even the moderate one has 200,000 ICU admissions that are needed there. Down there is what we have right now in the ICU in the United States. We have around 47,000 medical ICU beds. Ramping up, we can maybe double that, but it's again very limited. So hopefully we do not see the moderate scenario, and the severe scenario is even worse. What are we doing? We have a task force for COVID-19 that meets quite regularly, and we are walking through all these steps that we can take, and we try to provide you as much information as possible. So here's actually the COVID-19 intranet site. You see that on top here. And if you click on it, you get actually to the lower one where all the information, the tip sheets and everything else is listed. So I think Chris may talk about that a little bit. These are kind of the changing definitions for a case. So that was in 3.11 that we actually got the newest ones for it, how to actually diagnose or how to find patients that we would like to test for COVID-19. So they are changing, and please kind of bear with us. We're not holding back information. It's just very fast, rapidly moving, and we are trying to keep up to date. So for infection prevention, we try to provide you the guidance information in time. Again, the web page has all of these. This is one of these sheets, and again, we have to update these frequently because the CDC and the state is coming out with new recommendations. Right now, we are placing patients on special airborne contact precautions. That will probably change in the next few days, so we're working on that. The state and also CDC now goes more to droplet isolation, so we are moving also to that. Staff engagement is really important to actually kind of also limit kind of the amount of anxiety that might be growing. So we are giving daily updates at the safety huddle about where the numbers stand. I'm and other folks are giving a lot of presentation and talks like this one here, and we are promoting healthy behavior. So the best thing that you can do is frequently wash your hands or use the hand rub solution. Both of it is very effective in killing COVID-19 and disrupting the transmission of that virus. Just make a point not to touch your face. I know it's very hard because that's just ingrained in us that we are doing it over and over. So just make a conscious decision not to do that. And I'm trying it too, but it's really hard. Then please clean frequently surfaces that you are touching. And the one surface that you're touching the most is probably your cell phone. Yeah. So look at it and wipe it down. You can use pretty much the AF3 wipes, the Grey Top wipes that are everywhere here. They are killing also human coronavirus. You do not need to use bleach, etc. So I think that's kind of what I just brought here, the tub there. So this is kind of what you can use. And no, I'm not traveling with that tub. Yeah, so.
You brought it in here.
Yes. Okay. Good point. Yeah. So respiratory etiquette is, of course, for sure we are following it all, that you're not directly sneezing and coughing, but you cover it up. Social distancing. Avoid handshakes. Explain that to your patients. This is not personal. Yeah, this is just kind of to avoid transmission there. So fist bumps are also not the best idea. Just say hi. Yeah, that's kind of, I think, the best way. Also avoid gatherings like this here, so large groups. Then do not go on a cruise. Yeah, not a good idea. These are swimming incubators. And you never know who came from where and maybe carry something. And then trips to Italy, I just had that from last evening. So again, a beautiful country, but just look at the news, what they are dealing with. Maybe not a good idea to travel to these hotspots right now. You may get in, but you may not come out. So just a thing to consider. What is really important, I think we are all kind of in that, it's not only a pandemic, it's an infodemic. So you get a lot of fake news out there. So my recommendations when I talk to groups is look at, select some of your outlets, news outlets that are trustworthy to you, and don't look at them every 2 minutes. Yeah, it doesn't help anyway. So just make a point. And also, if you hear misinformation on Facebook and all the other wonderful things that are around there, try to counteract that with real information and try to also kind of tell that to your patients. There are household preparations if you are kind of in that round. CDC has them online, so take a look at that. It's very helpful to prepare. I think there's always a rush for toilet paper in these instances. I don't know why, but I think Costco should be out by now, so whatever it is. And then if there's really a lot of anxiety level in your team members, and maybe you experience that too, we have the employee assistance program available for you, and it's all confidential, but you can pretty much get some help if you are in that stage. Really important is conserving our personal protective equipment. So these are surgical gowns, masks, gloves, all that stuff that you are using to protect yourself. So it's not that we forgot to send in a form to order new stuff. That's nationwide. Yeah, so we are not the only ones kind of dealing with that. And there are some tips how to do that. Boiling it down is really be conscious if you are walking into a patient room, what do I have to do? And also, do I need 5, 6, 7 other folks coming with me, students and all these things? Yeah, especially for isolation rooms where they have to put on PPE, reduce that, maybe leave them outside and then come out when you have done whatever you have to do inside the patient room and take only one in there. What is really great and very effective is provide actually surgical masks for your patients that display respiratory symptoms. So if they are coughing and sneezing, give them a surgical mask. That's a fantastic precaution to actually interrupt the spread of viruses. You will be protected, the environment will be protected, and I think your patient also appreciate if you say, okay, we can do something about that. So what's next? And I just got that this morning. So it's officially now a pandemic. Yesterday, WHO has declared that. Does it change anything for our preparations? I don't think so, but now it's a pandemic. And what is kind of copied out of that, what the director, WHO director said: first, prepare and be ready. Second, detect, protect, and treat. And third, reduce transmission. And fourth, innovate and learn. So these are the key points that he actually got in his announcement. There are definitely more cases that we will see in North Carolina, probably also human-to-human transmission. It's all run by our capability to test people. And that's really kind of where we are struggling with. The state has test kits, however, that is limited. And then we have now commercial labs actually kind of that are available that we can send isolates to, but we have to be really kind of conscientious and saying, okay, who do we test? These have consequences for your patients that are under testing. The turnaround time from at least LabCorp on the website is 3 to 4 days right now. I can guarantee you they will be overwhelmed with tests. Probably it's a longer period of time. If you have a patient under investigation, the PUI, for COVID-19, that means if the patient can go home, that the patient has to self-isolate himself or herself. That may be really challenging for some of the patients that live paycheck to paycheck, etc. So do not take it lightly, but really make a point to see, okay, who do you want to put under this PUI? We haven't had a patient admitted here with COVID-19. And again, the same applies to us. We are limited in our PPE, and we will use a lot of PPE to take care of these patients. So, and we will continue, of course, to work with our regional colleagues, Cone, Novant, etc. We already had visitor restrictions coming out yesterday. That was coordinated effort to pretty much have all the institutions follow the same guidance. I think it's a great sign for the community and also for the media to say, you know what, one hospital is not better than the other or doing more than the other, etc. So we are trying to run that too. And then the last thing, again, be really mindful with your PPE. Use it only when indicated, but then use it. And otherwise, I think I'm pretty much done and we can open the discussion.
Yeah. Let me, I have a few comments before we open it up to questions. And as most people know, I'm wordy, so if I go on too long, just cut me off. First, my name is Chris. I am a face toucher. So this is Grand Rounds, so let's just interject a little bit of science into this because it's actually the fun part. So where did this virus come from? Nobody 100% knows for sure, but this is a classic example of an emerging infection of a zoonotic origin, zoonotic being from an animal. Probably the animal in this case is a cute little guy called the panelin. You can Google it, panelin, and you see the cute little pictures. It looks like a little anteater. The Chinese love them, and they actually have eaten all of them on their country, and now they're importing them from other places. The panel COVID virus genome is what, 98, 99% homogeneous or homology with with the current circulating SARS-CoV-2 virus. There's two places that are mutated in that make that virus a little different. One place is a mutation that confers where the spike of the coronavirus is. So if you remember the beginning of the slide, coronavirus is round and it's got these little spikes sticking out. Those spikes are actually the receptor binding domain of the virus, and that mutation actually allowed the virus to bind to the human ACE2 receptor in our lungs. And that is why it is capable of infecting humans. It's new, it's different, it's novel. The other place that mutated was in the place that allows the virus to cleave off the cell and then go from human to human after cleaving, kind of like how the neuraminidase works in influenza. And so now you have a virus that can infect humans, and it also can spread from human to human. Voila, a human infection is born. The ACE2 receptor thing is interesting. So if you think about it, would an ARB work to help prevent this? We don't know, but it's an interesting thought. And also protease inhibitors and such seem to have some utility in preventing replication of the virus and cleavage off the cell, and there are now trials going on, some here in the US, using those to see if it would work. So that's a little bit about the science of the virus. The transmission in humans, there was a study that was in pre-publication that came out this week. Hasn't quite been peer-reviewed yet, but was important enough to get out. That shows that when you first get sick with this virus, the incubation period on average is about 5 days. And you have a mild illness at the beginning of it. During that time, you unless you're really thinking about it, you probably don't know you're going to be getting sick. But it's kind of like that pre-sickness feeling that you have, you know, a little scratchy throat, kind of a cough here and there. So people tend at that phase to go out and about their usual states of business. Unfortunately, at that time, a person is shedding a lot of virus. There's probably not a lot of asymptomatic shedding, but early in the stages of infection, there's a lot of virus getting spewed out by coughing and such. This then gets into the environment on fomites, can be picked up on the hands, face touching happens, and voila, now you're infected. It seems that most of the shedding in people who have mild to moderate cases of virus is over by 5 to 6 days, which is not unlike influenza. The problem is we use molecular testing. Molecular testing to confer how long a person is infectious actually is picking up genomic material that is probably not infectious anymore. So the tests are positive for some time after a person has had the illness, even though they're not infectious anymore. Remind you of Zika a little bit, right? Zika and semen is viable for maybe only 3 to 4 weeks, but you can find it by molecular testing for 6 months. So we're going to have to wrestle with that a little bit, but it is a little bit, I think, encouraging that people don't have these long periods of being infectious. Let's talk a little bit about pandemic responses and responses to an epidemic. There's basically 3 phases to this. The first one is that of containment, and that is in the phase that we're in now. Containment means that you find somebody who has the virus, and then you do all of their contacts and talk to them, and then you isolate the person who is sick, and then you put the contacts in quarantine. That helps to slow the introduction of a virus into a population or community, and in the best scenarios can actually stop an outbreak. We're getting beyond containment now. Once you start to have people in a community who say, well, yeah, I got COVID-19. Yeah, wow, wonder where I got that. Now you're talking community transmission, okay? That means that it's circulating in a community enough so that people are being infected and they don't know they've been in contact. We call that sustained community transmission. So when you go to the CDC website, you'll see those terms a lot. If that continues, then you have widespread sustained community transmission. Widespread sustained community transmission. That means you probably have somewhere around 10% or so of a population that's infected. So if you think about an influenza pandemic, it kind of resembles that. Once you start getting into community transmission, you leave the containment phase of outbreak response and you go into mitigation phase. What does mitigation phase mean? It means you're going to try to slow that outbreak down. And if you look at it, and I'm sorry I don't have a slide, but you know, every epidemic curve looks like this, right? Cases go up, cases go down again. It's not rocket science. What mitigation tries to do is push down that peak so it looks more like this, so that the peak isn't as severe. And that's really important for us as healthcare, because when you get a peak like this, that top part of that peak means you got a stressed healthcare system. You don't have enough beds. You don't have the surge capacity may not be there. People are getting sick who work in your hospital, and your staffing starts to go down. Dogs and cats living together, it's horrible. It's chaos, okay, as Bill Murray said. So we try to push that down. One of the ways we push that down is through social distancing. And you're hearing a lot more about that now. Social distancing, keeping people apart, big gatherings, trying not to have places where people can get together to transmit virus. Also, it might help prevent what I now call the Biogen incident, where a group of researchers, including a bunch from the Research Triangle, went to the Biogen meeting up in Boston, and there was probably a super spreader up there who was capable of infecting lots of people. Now over 100 people in the United States have this, all from that meeting, including 5 cases here in North Carolina. And so there can be these little unlucky events that help spread it. Social distancing hopefully can reduce the risk of that. So what does that mean for us? So you probably have all seen our travel policy that came out yesterday, which is a little bit more restrictive than our original policy. And this is to try to prevent a Biogen incident from happening in our community, us. And it's also to help us with evaluating employees, faculty, students, and residents who might have traveled. And basically, this policy says that there will be no business travel, if you haven't seen it already. Yeah. Sorry, touching my face. Yeah. It itches, man, it itches. There's no business travel unless it's approved by a vice president. So for faculty, in particular, this is something. Personal travel is discouraged. We can't restrict it. It is discouraged. Please, please, please do not get on a cruise ship. I'm serious. Just don't do it, okay? These places, for ages, we've known are great places to circulate respiratory viruses, Legionella, flu, you name it. Don and I were in the Navy. An outbreak on a ship is a mess. You can't contain them. So just don't do it, because when you come back, you won't be working for 14 days. So there is now a page for those of you contemplating personal travel that through the communication yesterday, and you can get it through the intranet on the COVID-19 site, that outlines the travel policy. If on the personal side, you can click on a link on there which tells you which countries or regions, including in the U.S., that you go to, that when you come home, you will have to spend 14 days not working. Because we just can't have people coming back with infections to our place. The other thing on there is a link to the employee health site where you have to register your travel, and that's not so we can be nasty. It's just so that if something happens while you're gone, we can warn you and tell you that you have to call in and check in before you come back because you may not be working. So it's not. You could easily get stuck. Right now, for instance, last night, all of a sudden, boom, surprise to everyone. Europe is now restricted travel. No flights, no nothing. No one knew that was coming. Not even Europe. So anyway, you could get stuck. Anyway, that's just something to think about. The other thing is that I need to talk about before we get questions is testing. Okay, if you want to take notes, now's the time to do it. Okay? So as of noon, maybe, with a little luck, you will be able to order SARS-CoV-2, COVID-19 tests through Awake One. If anyone wants to have fun, do a Awake One build. I just did one. It's not fun. But anyway, you'll be able to do it. Here is the thing. There is going to be a read me first at the top of that. It is an order set. So you get it from the facility-specific site on Wake One. And then you look at the order set, which should be at the top, and then there'll be a read me first. It'll walk you through the process. First, you have to decide who to test. I have one very strong word of advice. Choose wisely. Okay, because there's big ramifications for testing. So right now, what I'm doing, I've kind of worked out this clinical decision process in my head, but unfortunately it's a little hard to put on paper. Since we don't have sustained community transmission in our area here, it means that not everyone needs to be tested. So you kind of fish for certain things that make them seem to be more likely to have it. One is having had recent travel, particularly travel to a place where there was a large congregate meeting or setting. So somebody just came back from a conference, or somebody who came back from an area where there's sustained community transmission, Seattle area, Bay Area, New York, right now are the big ones. And then seriousness of infection, if it seems to be a serious infection, lower respiratory tract, those are the people you would think. The first thing you want to do is test for influenza. If the influenza test is negative, then you move on to the next step. That next step involves doing 2 nasopharyngeal swabs. 2. One for a rapid the RVP, right, the respiratory viral panel. The other is going to be for the SARS-CoV test. Put them in separate transport media. So it's actually 2 separate tests. You have to order the RVP separately from ordering the SARS-CoV test. So it'd be 2 orders in Wake One. After you've done that, then you have to counsel the patient on what the implications are that they're being tested. This means you have to, it is the ordering physician's responsibility to tell the patient that you have to be in a self-monitoring, everyone calls it self-quarantine, self-isolation, until the test result comes back. You go home and you watch a lot of Netflix, okay? It's, and you really can't leave the house, travel, or go to work, or do those things. Now, there's a little bit of looseness, can you go through the drive-in line to pick your kids up at school? Probably. Things like that, but you're really not supposed to leave. Then you have to have the patient and you both sign a form that says that you understand that. This is required by the state. It's in state statute. After that, you have to fill out a person under an investigation form, which is basically the reporting form that goes to the state. It's about 2 pages. It's not horrible. It's not as bad as the CDC form. Once you've done that, then you send the sign form and then the PUI form with the specimens. It goes to the lab. We take care of reporting to the state with the PUI form. And then it's about a 4 to 5 day turnaround time right now. It's going to LabCorp. It's a send out. During that time frame, you are responsible for the patient's well-being while they're in that setting. Obviously, if they're an inpatient, they're going to be isolated and the situation's different. So it's all going to be walked through on that order set. You'll have the links to download the forms and so on and so forth. And it tells you what I just told you on there. So you don't have to try to find it on the internet. So I think I'm going to stop there.
Yeah, I think both of the great updates, Chris, Werner, thank you very much. I think that that certainly has put us frame. So Josh is going to go up and down on that side, and I'm going to go up and down on this side and just open it up to some questions and answers. And yeah, I didn't think there'd be much of a shortage.
Have we started testing here on any patients who have died recently of acute respiratory illnesses?
No, we haven't yet. We don't, testing autopsy specimens and such is right now, I mean, all that stuff has to go down to the CDC, and right now they're trying to concentrate on people who are alive. But yeah, that would be something to look at some point.
Chris, if we have a patient under investigation, how do we counsel them to advise their family members that cohabitate with them?
So it's all outlined on the patient information form that you give them on how to do that. Basically, you try to separate yourself a little bit from the family, but it's not 100% because they've already been exposed. So, separate bedroom and things like that. And you put a mask on the person who's the PUI. You just try to stay away from the rest of the family as best you can in the same house, but not too extreme.
Is durable? Is immunity durable? If I get it and I get over it, am I good to go for the year?
Well, the short answer, yeah, right, just go out and get infected right now, get it over with. The short answer is we don't 100% know for sure. There's a lot of stuff going on. It turns out that the antibodies produced against that spike protein are neutralizing. So maybe. And it also, we're looking to see how many people who had SARS in the past don't get this. And that looks like it might be encouraging. So more to come on that.
Chris, I was wondering about the test characteristics and sort of the sensitivity of the test, and if you had someone where the clinical suspicion was really high and that the test was negative, would you retest? But actually, before you answer, I just want to really thank you and Werner for all that you've done, in the past, several weeks with regard to helping us prepare for this. And, I realize that essentially you guys have been on call, 24/7. We are going to have to report you to the ACGME for 80 hours, violations. Yeah. But, the entire institution is really, grateful for everything, that you're doing.
Thanks, Gary. I appreciate that. So the test characteristics, highly sensitive and specificity, probably very specific. I mean, as most NATs are. if you have a high pretest likelihood and the test is negative, the negative predictive probability should still be good. And I can also tell you as an aside, because I've been getting like 40 or 50 pages a day on, should this person be evaluated? I'd say right now about 80% of them that we test through end up having the flu. This was not a good year for flu to just linger on like it is. Yeah, Ken will tell you. He just had it. But look for flu. We're still finding it.
Chris, I have a question over here.
Oh, yeah, hi. Oh, you just cut out.
Okay, it gets to Tim's question, which is, but I'm going to bring it in a little bit more, which is about what to tell family members. Because of the medically fragile patients that we deal with, they're panicked. And I think we need a consistent messaging to them that I've kind of not been able to get my head around. The other thing that, that came out today is that part of what controlled the spread of virus in South Korea was that they were quarantining people, but they were getting family clusters of the infection. And when they started isolating families from one another, they were able to interrupt that spread. So I would just
yeah. So I mean that's
further.
a complex question. The first part of it is there is some guidance on this on the CDC's website. It's a little bit general, but it's on vulnerable and immunocompromised people. I forget exactly how to navigate to it, but it's not horribly hard when you go to their site. And there's some help with that there. The other thing is that this population, the vulnerable population, the elderly and people who have underlying conditions, this is, a time to kind of lay low a little bit. It's, you don't want to be traveling. You want to try to stay away, particularly from people who might be ill. And just not try to expose yourself. If there is somebody in a family who's been identified and you have a vulnerable host in that family, the guidance is to try to if you can, separate, living dwellings if you can. So if the vulnerable host could go to a hotel, or the affected person can hang out in a hotel or something while the vulnerable host is there.
So Chris, can I follow up to that question? And this may be really to Ken and Werner, because it involves logistics as well. We get a lot of questions about my patients would like a prescription for a mask. They're immunocompromised, they're very anxious to have a mask, and I've been not giving them very straight answers because of, I think, lack of clarity of data as well as logistics. Would you address that?
That's you. And while he's answering, I think you got a question all the way in the back of the room back there.
So the situation for masks, and this is kind of pretty much including all masks that you can get, is pretty dire. I went to the Lowe's at Mayodan. They were out of pretty much everything that you can wrap around your head. So, and there is really not any great advice that I can give right now where you can actually kind of get masks, and that is a real problem. We actually just got a few masks to the Forsyth Health Department. So, it's from that standpoint, it's pretty dire.
We had one way in the back, yeah.
Thank you. Can I just ask, as we're all starting to develop sectional plans for every specialty in medicine, specialty in surgery, can you give us some guidance? Should suspected patients be seen by a single faculty member, avoid fellows, house staff? Can you give us, so we don't end up with 500 plans, advice?
Yeah, so part of that, so I've been in discussions with the med school also. So we're trying to conserve PPE as much as possible, which means trying to limit the number of people in the room. And we all know how rounds go, and when we go to visit patients, how everyone troops in. Not everyone needs to go in, but we don't want to kill the educational experience also. So, if the med student assigned to that patient can go in, but you also have to see how much educational value there is in assigning a med student to a patient who needs to be isolated. Sometimes there's not much value, and then assign them a different patient. As far as trying to keep one person to go in the room versus others, generally we're not saying anything about that. So there's some FAQs out there somewhere, and I don't know if they're actually published yet or not, but what it says is that if you are a vulnerable host yourself, in other words, you have underlying health conditions, or you're pregnant, then you may not want to be in the room for an aerosol generating procedure, like an intubation or a bronch, if you ever do one of those. But otherwise, you can care for the patient as long as you're using correct PPE. I think Werner had mentioned that, PPE works for this. And if you do it right, you don't get infected.
Can I ask just a quick question? If the patient is at home, they've been exposed to someone, like just say from the Biogen conference, and they were at home and they called you and they said, I have a fever of 102. What should I do? What would your advice be for that?
Yeah, well, so if it's your patient and it's impaneled with us, then that patient should be tested because if they're a known contact of a focus, they should be tested if they have fever and respiratory symptoms. Where that testing is done is a little bit a work in process. It could be done in 3 different places. One is it could actually be done in the person's home, and that would require somebody to do a home visit and PPE and get the specimens. There's advantages of that, obviously, are not exposing a lot of people. The disadvantages are logistically it's harder. Technically, the health department could do it, they're busy though. And so if we can help them, it might be good. And I'll let Werner chime in on this because this is a really important point. But yes, you can do it in a clinic. You can do it there. And I would rather have it be done in a clinic personally than in the ED. Right? ED people, yes. And I mean, it's just like anything else. So your first question is just like any other triage question. You have to figure out how sick is the patient. If the patient is ill enough that you think might have, needs further evaluation quickly, like in an emergency department setting, like you would at any other time, then that would be the thing to do. Right? If call 911 or whatever. So that doesn't change. You have to evaluate how ill the patient is. If they're not that ill, seems like they have a cold or the flu, and they're a known contact, right now, I would say test them. Probably let's do it in your clinic. Have them call the clinic ahead of time, or you call the clinic ahead of time. They're met with a mask at the door. They're brought into a room straight away. Put on droplet transmission, right? That's where we're headed. And then you can do the evaluation and testing. Yes, it could be done in a clinic. This is not Ebola. So as time goes on, and we start getting into community transmission, it might be okay to say, hey, yeah, you could have it. Could have the flu, you could have that. What would you do if you had the flu? Stay home. Don't go to work. Don't expose other people. And that's when we're full in the mitigation phase. But right now, since we're still doing containment, I'd probably test them. Does everyone agree with that?
Yes.
Yeah.
Dr. Jodo's been holding the microphone for a while. Two-part question. One, how long is the virus transmissible on inanimate surface objects like around the hospital door handles, things like that? And two, are we being much more diligent about discontinuing isolation precautions on patients who receive treatment for certain disease conditions so we can reserve that PPE for patients who really need it, as opposed to keeping patients cycle PPE downing
Yeah.
So for the first one, at least 4 hours. That's kind of studies with other human coronaviruses. They can survive for that time period, and it can go up to a week. So definitely clean frequently the surfaces with the wipes like this. And what was the second question? Discontinuing. Actually, our infection prevention team is going around and looking at every patient on isolation on a regular basis and seeing if we can actually take them off isolation. So that's a proactive activity that we are doing here to really get our PPE usage down. And what I hear from my infection preventionist is that at least 2 or 3 per unit per day we can maybe kind of talk about. But that is really with the attending there, with the folks on the unit to see if it's appropriate.
Are we doing influenza tests of cures now? So that's kind of been something that's been murmured. Like, do we see RBPs kind of clear patients of flu given a droplet?
No, what we are doing is pretty much we are looking at the symptomatic picture of the patient, if they are asymptomatic for a specific period of time, if there are no other underlying conditions like immunocompromise, etc. in these patients, then we are discussing if we can take them off.
We're obviously running out of time. People are leaving. We got important questions. We got one or two more important questions. I'm going to intercede and just because Cindy asked, I think, a really critical question that I know needs to be asked. Want to shout it out?
Oh, my question is, what do we tell our patients who are scheduled to come to clinic, who are, as far as we know, well, but vulnerable? Should they be told not to come to clinic? Should I just call and check?
That's a good question. I think they can come to clinic right now. Once we get into widespread transmission and get up around 10-15%, like, in other words, whoa, it's really a bad flu time kind of thing, then maybe they would not.
Will you communicate that to us as a group when it's time to not have those people?
Oh yeah, you'll know. You'll know. Yeah.
First of all, thank you guys so much for taking the heat off of the rest of us. But we are getting questions about, hey, if I'm going to be taking care of patients with COVID-19, should I just plan to stay at the hospital so I don't take it back home? And if so, are there institutional spaces that folks can use, like call rooms for faculty?
Great. So first of all, again, great question, and thank you very much for putting me on the spot for that one. So, yeah. So we are actually working in the task force and identifying places. If that comes to that stage right now, it's not necessary as we see, but moving along and seeing kind of how it goes, I think there will be discussions where we can place folks if they feel uncomfortable going back home.
I've had the mic for a long time.
Yeah. The other thing to keep in mind is, as these experts have said, is PPE works. Yeah. But PPE only works if you use it correctly. And by midday today, I'm thinking we're going to have a training module out for correct donning and doffing procedures. Pay particular attention to the doffing process. If PPE is going to fail, it will fail you in the doffing process. But as long as you use the PPE correctly, at this stage, there should not be a threat of taking it home.
One other quick follow-up to that question I think is important to think about. So right now, as we move into community transmission, which we will soon, you'll have to, we will be taking care of patients in the usual way that we usually do. Our usual procedures for doing it, our house staff responses will do it the usual way. Because the numbers will be small and we should be able to care well for these patients doing the usual thing. That is the safest way to provide medical care. Don't leave what you normally do. When and if it gets to a point where we're having to pull surge capacity and starting to do things that are outside of our usual operating procedures, that is called a disaster.
Crisis standards.
Crisis standards of care, yes. And then we start doing things like shifts, taking care of people, finding alternate places to care for them and such. Don't worry so much about that right now. I mean, hopefully we don't have to do that, but right now, start prepping for taking care of these patients in the usual way we take care of patients, and we integrate it into our procedures.
I think we got time for one more question.
So this is related to that question. Can you comment on the location of the hospital where these patients will be cared for? Will they be cared for in the usual locations of the hospital?
They'll be cared for where it makes the most sense, like we normally do. So if they need ICU care, it'll be in an ICU, particularly ones where they have, ability to isolate. And then on the wards in those areas. I don't know, are we still putting them in airborne transmission? Initially, they'll go into an airborne transmission room and then moved out as we evaluate them.
Well, thank you all for being here. I'm sure this will not be our last update on COVID.
I guess I owe you two a